Play on camera. TV.
Tak dengar.
Tak. Nisa kena, Nisa duduk di sini. Kau duduk dulu. Kau on kamera. Nisa duduk sini. Sini.
Testing 1 2 3. Testing 1 2 3.
Sebagai kini 7 second.
Oh, 7 second. Okay. Ini tak payah aku.
Cakap dia apa pun.
Baca.
IJN Paediatric. Keadaan ICU berada neonatal crisis. Testing 1 2 3. Let's say phones. We'll be live on at 6 p.m. Thank you.
Ni pun nak gambar je ke? Ni apa? Slideshow.
Ya, ini memang slideshow dia ada rotate. Saya buat dia rotate. Bye.
Nisa boleh dengar. This particular link lah, siapa-siapa pun boleh guna. Yeah, so those people who registered also, if the thing is full at 500, they cannot enter also. Huh? Huh? Siapa cepat dia dapat kan?
Ini sama. The presenter cannot even log in.
But nobody is that punctual.
6 o'clock we starting, right? We
Yeah.
can start before people come in now.
Hai Nisa. Hi, Nisa. Hi, Nisa. Can you hear me? Okay. All right. Thank you.
need to test out the sound.
Testing.
You're presenting.
Testing. I'm testing now. Can hear or not?
Yes, I can hear you.
Oh, all right. Great.
Oh, Joyce.
Yes. Can you hear me? I can hear Eugene just now. Yeah,
Okay, excellent.
excellent.
Hello. Can you hear Dr. Joyce?
Can.
Dr.
Can.
Su whispering, can hear or not?
Can. He whisper but cannot hear clearly, but background talk. Yeah.
That one cannot work.
Yang benda ni tak boleh.
Saya email lah.
So you can only hear from here lah. Oh, this one lah.
Only this
is the
one,
primary. So this one when Shuku presents that time also need
Boleh
to.
keluar. Ya.
Tadi hilang.
Oh. Is this okay or not? Yes.
The first one can hear clearly. I think the other one cannot hear.
The other one cannot hear.
Now can hear Eugene.
Oh. Cannot lah. Only one speaker can work. This one how?
Oh, tak lagi.
Oh, tak lagi. Tak lagi.
That one doesn't work lah, that one.
Huh?
That one.
Tak, sebab ni tak clear.
Ni apa? Nak install ke nak buat now?
Then you can reduce the participant number so that you can increase the actual participant number. Here you are using 2 participants or 1?
Huh?
Guys, still cannot hear. Dengar ke?
Now can hear. Are you right in front of the microphone? Now I can hear you.
Now can.
Now can.
Oh, alright.
It's
Boleh,
working.
boleh.
Then
Boleh lah.
Boleh.
Jalan.
Bagus.
The mic working or not? I mean the video working or not?
video working.
The video feed.
But we are shy.
I can see.
Or video there. Then what, when Shuko want to video that time Shuko?
Yes.
Oh.
Or Shuko also have to use that computer to present?
Oh, okay. In that case, I open up first.
So you can see Eugene or not? Can you see Eugene?
Yes, I can see Eugene.
Then
Yeah,
you
alright. Learn. Can't see picture. What?
you got no video feedback.
Never mind, it's fine. Hey, you cannot see the other people.
Because nobody log in punctually, man. Why got people? Why got
Got,
people?
Yeah,
got
okay,
people log in already.
So cannot synthesis.
I think it's
Yeah. For us, yes. Where's mommy's one? Who's that?
Hello. Good evening, everyone. I think let us wait for 5 minutes and then we will start our webinar. Okay?
Joyce, attendant link ada ke?
Oh, ada. Dekat chat box.
Ha?
Chat box. In the chat box.
We are live. Let's start.
Yeah. Hello. Hi. Good evening, everyone. And in some part of the country, it's good afternoon. Yeah. Welcome to today's PCICU webinar. This is our first webinar series on cardiac intensive care, and we hope there'll be many more to come in the future. So we are starting off with neonatal series, and then subsequently we will have infant, pediatric, and the adult congenital, right? Yeah, so we are privileged today to have our expert panelist, Dr. Su Kok Wai. He's the consultant pediatric cardiologist and also the cardiac intensivist in our ICU in Institut Jantung Negara. and Dr. Khairul Faiza, our senior consultant, pediatric cardiologist, and also our cardiac intensivist at our center in IJN, right? So we hope today both of them can share with us their knowledge, their experience, and also their practical approaches to these complex clinical situations, right? So today's session will focus on two very important and challenging neonatal presentation. We want to look at the shock newborn, whether this is sepsis or this is left heart obstruction, and also the blue baby. They are cynos, but they don't have a respiratory distress. These are actually critical scenarios that require timely recognition, careful assessment, and also prompt management to improve the outcomes in our in these newborn babies, right? So we hope this session will be insightful, interactive, and also beneficial for everyone involved in neonatal and pediatric critical care. Okay, so some housekeeping rules. Please keep your Zoom muted, and if you have questions, and you can actually put it down in the chat box, and we will discuss after the case presentation. Okay, so without further ado, let us begin our webinar today. Our first speaker will be Dr. Eugene. He will be teaching us, guiding us on the shock newborn, whether is this sepsis or left heart obstruction. Over to you, Eugene.
Hello. Okay, thank you, Dr. Joyce, for the introduction. So I will begin by sharing my screen, and then we'll get right into the lecture. Okay. Can you see my screen sharing? Dr. Joyce, can you see the screen?
Yes.
Yeah, okay. All right. Good evening, everyone. So I'll be talking about the shock newborn. So is it sepsis or left heart obstruction? So the outline of this will go through a case study and subsequently differential diagnosis of neonatal circulatory shock. Then I'll go into detail regarding left heart obstruction, the prevalence, pathophysiology, clinical findings, and subsequently management. So the first case study, day 9 of life, born term, good low birth weight 2.34 kilo via SVD. So uncontrolled type 2 DM and GBS positive. Discharged home well at day 2 of life. Presented with circulatory shock to emergency department. So the two things that will play a role is type 2 DM is highly associated with cardiovascular problems and other issues, as well as a GBS positive indicative of differential such as neonatal sepsis. So for the history, patient was previously well, discharged well, at home, bottle fed, active at home, and then suddenly presented with a rapid breathing, chest retraction, and pallor. Other systemic review were negative, and there was no family history of consanguinity. So on clinical examination, was sinus, brachial pulse weak, oxygen saturations were low at 80%, and BP was 50/30. And respiratory rate was 70, heart rate 160 beats per minute, temperature 37 degrees Celsius. Lungs had crepitations and CVS, there were no murmur. Abdomen there was hepatomegaly of 4 cm. So the question posed to you all is how to stabilize and what would be the differentials. Right, I just see if there's anyone from the floor. You're right. So basically, how to stabilize? Everyone will manage similarly. This kind of saturations, oxygen, intubation, and then with a low BP of hypotension, there'll be a fluid bolus and a consideration of inotropes. So what would be the differentials at each stage? Usually it'll be, most common is going to be sepsis. And then after that, so with this talk is a left cardiac output obstruction, as well as an inborn error of metabolism as well. So because the pediatrician is smart, so they decide to check further stuff. So the femoral pulses were not palpable. The oxygen saturation over the upper limb, there's a discrepancy, 95% over the right finger, and pulse is 80%. And there was a BP discrepancy as well. All these point towards a left ventricular outflow tract obstruction, which is a cardiovascular congenital heart disease. So investigation done show pH 6.96 is a severe acidosis, bicarb of 11.5. So it's a severe metabolic acidosis with a lactate of 17. Glucose was still 10. So if you can see from the X-ray, there's a cardiomegaly, congested lung fields, as well as a hepatomegaly as well. So here I'm just going to show some of the echocardiography findings. So from this, seeing a fairly balanced chamber with a good cardiac output. So there's a VST with a left to right shunt and a roughly small aortic annulus. Okay. So over here you can show that there is a VST. And then from this view, you can see that the pulmonary artery is actually very dilated with pulmonary regurgitation. And then over here, this is actually showing an interrupted aortic arch. So this flow of blue is actually showing the flow from the PDX supplying the lower descending arch. And over here as well. Just follow the arrow over here. So diagnosis is interrupted aortic arch type A, as well as a perimembranous ventricular septal defect. So the management is clear. It's going to need to start a prostaglandin as well as a referred for aortic arch repair. Okay, so now we have looked at the interrupted aortic arch. So let's see how else can a left ventricular outflow tract obstruction present. So day 11 of life, born term, 2.65 kilo, cesarean section. Once again, GDM on insulin and discharged home well at day 2 of life. So this presented differently with a respiratory distress and then during follow-up. So GDM is an indicator that you should think of some things like that, of cardiac cause. So patient was well, had sudden respiratory distress, systemic review was normal, and there was no family history of consanguinity as well. So clinical examination was similar as well. Tachypnea, femoral pulse, BP was low, oxygen saturation also showing similar findings, where there is a discrepancy of upper and lower limb findings of oxygen as well as the blood pressure. Tachypnea and tachycardic, but temperature was normal. Here, bilateral crepitations over the lung, and you hear a systolic murmur. Immediately, you're going to think, is this a cardiac cause? So the chest X-ray showed cardiomegaly and increased pulmonary vascular markings. And looking at the X-ray over here, you can see that there's cardiomegaly, congested lung fields, and the liver also is large. So this is the echo. So the LALV left-sided chambers are more dilated. So this is LALV dilated. So over here you can see that there is a VST over here, and then there's a outflow tract. This is the left ventricular outflow tract. So there's no obstruction at the level of the aortic annulus. And over here you can see a VST. This blood flow is going from here, going upwards. So this is the left to right shunt. And over here, showing this is the pulmonary outflow tract. This is the right ventricle supplying into the pulmonary arteries. Okay, so this is the interesting part. So you can see that the aorta actually looks quite small, and then at this section, it actually starts to taper down. So from this, I'd like to highlight and show that actually what we look for in the echo is that you need to look for this diastolic runoff when you are doing the echo to look for coarctation of aorta. So there is a diastolic runoff. So once again, showing this hypoplastic arch, and this is a different view, showing that the descending aorta actually quite large actually. So this section over here, there is a coarctation. So diagnosis is a hypoplastic arch with a coarctation of aorta. Right, so the management is similar as well, of prostaglandin infusion. Unfortunately for this child, developed non-occlusive mesenteric ischemia, or similar people will say NEC. So looking at this, there's a pneumatosis intestinalis over here. So the coarctation of aorta was tented and aortic arch repair was done 2 months later after surgery for non-occlusive mesenteric ischemia. Okay, so now we've looked at coarctation of aorta, we've looked at interrupted aortic arch. So now I'll go into the differential diagnosis of a neonatal shock. So the main differential still, even though this is a cardiac lecture, we still should always be sepsis first, and it's always sepsis first. So by the history taking, you see lethargic, abnormal cry, grunting, apnea, poor feeding, pallor, hypothermia. Basically, all this is show signs of inadequate perfusion to the brain, to the lungs, to the other parts of the body, causing poor feeding, pallor, or hypothermia. So antenatal, the risks are prematurity and risk of infection. So the likelihood that when you see a patient with circulatory shock, most of the time is sepsis first. But for the other 40%, you need to consider something else. So the other differential diagnosis of neonatal shock is also inborn error of metabolism. So the history taking the priority will be consanguinity and early neonatal death in previous children. So when looking at inborn error of metabolism, most of the time you're going to look at small molecule disorders. Basically looking at this section, this is taken from Dr. Ngu Inborn Error Metabolism Survival Guide. But basically you'll be focusing on this section here, which is organic aciduria and urea cycle defect or maple syrup urine disease. So basically the gist of it is that there's accumulation of toxic substrate. In urea cycle is ammonia, and in organic acidemia is organic acid and ammonia. All this will lead to the things which are like presenting with shock as well. Okay, so I just go through briefly on the urea cycle. Basically, it's a cute baby drinking protein. Then after it's broken down into amino acid. So what happens to this amino acid is going to come over here. Then after it becomes ammonia. So ammonia is going to go through this cycle over here. So you see at any point of this pathway, you can get block over here, block over here, block over here. So where does this ammonia go? This ammonia accumulates in the brain. And then you get this cerebral edema. And you get this hyperventilation like in our patient and respiratory alkalosis and cerebral edema. After what happened? You hypoventilate because the brain becomes the cerebral edema. So you get hypoxia, hypercarbia, and eventually you get collapse and acidosis. So this is for urea cycle defect. So for organic acidemia, it's a bit different. You get a cute baby drinking protein. And then after that, this protein comes down over here. So these pathways are blocked. These two components are basically acid. So this organic acid accumulates leading to metabolic acidosis. So usually this is a common aciduria. 2, 3, 4. Then after what happened? When this gets blocked, this pathway also gets blocked, which is the urea cycle, because of the accumulation of organic acid. So you lead to a rise in ammonia. So you get metabolic acidosis from the organic acid, and you get ammonia that is risen because of the urea cycle that is blocked as well. Okay, so now we're going to talk about left heart obstruction. We've covered neonatal sepsis, we've covered inborn error of metabolism. So now we'll talk about left heart obstruction. So the obstruction can occur at what levels? So the level of the ventricle, the level of the aortic valve, or the aortic arch. So like the previous cases we have seen is at the level of the aortic arch. So if it's the left ventricle, you can get this hypoplastic left ventricular left heart syndrome. So basically it's blocked over here because of this underdeveloped left ventricle. And if it's at the aortic valve, you can severe aortic stenosis. So it can be subvalve, valvular, or supravalvular. So there's an outflow tract obstruction over here. And then the third kind, if it's the aortic arch, so you get this coarctation segment over here. Or over here, if you get an interrupted aortic arch, which there's no blood supply across this section. So the prevalence in Malaysia of congenital heart disease is 7 in 1,000 live birth. So you can see there's a dip from 1960 to 1990, and subsequently now at 7 in 1,000 live birth. Okay, so if you were to see this congenital heart disease, how likely is it? Out of that, the coarctation of aorta is the most common, 1.8% out of the total. And then aortic stenosis, hypoplastic left heart syndrome, and the least likely is the interrupted aortic arch. Okay, so now going through the pathophysiology, so we don't need to memorize. We just remember the pathophysiology, understand it, and then you can derive everything from there and decide how you're going to manage the patient. So we'll use the coarctation aorta as an example. So with the PDA open, you get blood flow from the pulmonary. So there's a narrowing over here. So the distal aorta needs to be supplied by the PDA. So the blood comes through the right ventricle, go up the pulmonary artery, goes to the lungs, as well as supply the descending aorta. So what happens? Your child suddenly PDA closes and then you present with a shock. So what happens? This is blocked. So there's no flow going to the descending aorta. So all the blood from the right ventricle comes up the pulmonary artery. All this blood is supposed to go to the aorta, now actually gets shunted all into the pulmonary artery. So what happens? Distally, you have no blood flow, so your effect is a low BP distal to the coarctation. Because all the blood is going to the lungs, is coming back into the pulmonary veins and down into left atrium and your left ventricle. So suddenly your left ventricle is overloaded. You get a left ventricular hypertrophy, and this blood is going to pump up here, and then it's going to go, all the blood is going to come up to here. So you get a high BP at your right upper limb, and then you get a BP that's very, very low in your lower limbs, which is a shock. So after that, your high atrial pressure, there is a shunting from the left atrium to the right atrium, and then down into the right ventricle. So you get a right ventricular overload, and because of this, you get a right ventricular hypertrophy. After that, all this blood pumps. So initially your blood goes here. Now all the blood is going to go to the lung. So you get a lung congestion. So at the end of the day, you're left with this picture. We show that you have a pulmonary, there's a congestion. So you get a biventricular hypertrophy, you get a cardiomegaly, hepatomegaly, you get a lung congestion, respiratory distress, and lung crepitation, and you get a low BP distal to the coarctation, which is systemic shock, poor peripheries, poor pulse volume, and hypotension. So upperly, as mentioned earlier, you get a BP discrepancy. Okay, so what are the significance of the clinical findings when you see a patient? So from this article, actually, the most likely that you're going to see is actually a weak femoral pulse. Weak femoral pulse, if you feel that, it's most likely that you're going to be looking at this cardiac is a shock likely due to a cardiac origin. Cardiomegaly on the second, and then after that, murmur and cyanosis. But take note that the sensitivity of the murmur actually is 0.56. So we always remember snout, which is to rule out. So if it's low, if there's no murmur, you actually cannot rule out a left ventricular outflow tract obstruction. Okay, now going on to investigation. So we've done the examination. Now we do the X-ray to confirm what we suspect. So X-ray and echocardiography. Basically, when you do that, you look at the obstruction at the level aortic valve, ascending arch, transverse arch, descending arch. So looking for coarctation, hypoplastic arch, interrupted aortic arch. And if this is blocked, you need to know, okay, what is supplying the descending arch, which is your BP, and providing your child with circulation. So you need to look at the PDA, is it present? How large is it? Okay, so to manage, basically we need to relieve this left ventricular outflow tract obstruction. So we'll start prostin. Then you have to look for the end organ dysfunction due to the insufficient perfusion to the distal to the narrowing of the left ventricular outflow tract obstruction. So usually it will manifest with mesenteric ischemia, renal dysfunction, or liver dysfunction as well. So after you've done all this at like periphery hospitals, then now comes down to helping us from IJN to see whether how you're going to optimize the patient before surgery. So usually you'll be like, oh, waiting for IJN to accept the patient. So in the meantime, what are the goals when you see the patient day to day? So the goal actually, you need to avoid the lung damage. Not too much blood to the lungs will cause a lot of lung damage. Too little, it will be hypoxia. And the second thing is to optimize the systemic perfusion. So if not enough, you can give things like adrenaline to increase the cardiac output, increase the distal perfusion as well. So too much blood or too little. So it's like the Goldilocks. You just need to give just right. So I'll explain this, how to avoid lung damage. So this is a sample of severe coarctation of aorta. Okay, so we need to prevent too much blood going to the lung. You can see the PDA supply here goes to the descending arch, is also supplying to the pulmonary arteries as well. So if you were to stand here, the blood is going to think, is it going to go to the pulmonary artery or going to the descending aorta? So the blood flow will pick the path of least resistance, definitely. So how do you reduce the blood flow going to the pulmonary artery and more to the descending aorta? So you need, so basically the principle will be, if you increase oxygen, the pulmonary vascular resistance will reduce. If you reduce carbon dioxide, also will reduce the pulmonary vascular resistance. And if you increase PEP, the pulmonary vascular resistance will increase. Okay, I will give further example for this. So the thing about PEP, the pulmonary vascular resistance, you can see that the curve actually goes down and up. So when your lung is fully collapsed, the resistance is high. When you have just enough, the actually resistance will come down when you inflate enough. But when you overinflate the lung, your actual pulmonary vascular resistance actually increases. Okay, so if you already confirm the PDA is patent, how are you going to manage? So the way is that If let's say too much blood is going to the pulmonary artery, means the pulmonary vascular resistance is low. Usually this kind of scenario, the FiO2 is high, the CO2 is low, and the PEP is low. So you're going to be in trouble. You're going to get lung that is so congested all the time. So this is bad. When we go into surgery, it's very difficult to manage. So ideally you should make sure all the blood go to the descending aorta. So how do you do that? So by increasing the pulmonary vascular resistance, by ensuring you reduce FiO2, you can increase the CO2 by using lower tidal volume and increase the PEP. Then you get a perfect looking lung. Then we are very confident going to surgery is fixed. And after that, the patient can be extubated very quickly. Okay, so what saturations and BP to target is the magic question. So again, we need to make sure a lot of blood go to descending aorta. So the right hand target is 90 to 95%. Lower limb target generally is lower than the upper limb, but it depends on the condition, coarctation, interrupted aortic arch. They have different saturation targets. So PCO2 less than 60, so it's a permissive hypercapnia, as long as the pH is acceptable. Upper limb BP, which will be usually hypertensive, so usually you take less than 95th centile for age, which will be hypertension, and lower limb BP generally mean BP of more than 40. This is in the neonate, so that there's enough for systemic perfusion. So usually kidney, liver, that it should be enough. So aim to increase systemic perfusion by increasing the pulmonary vascular resistance. How to do that? So reduce oxygen, even down to FiO2 0.21, don't be afraid. And increase the CO2 by permissive hypercapnia, reduce the tidal volume or reduce the rate. And increase the PEP. So the other thing, if let's say you assess the child and you see there's feeding intolerance, there's AKI, there's transaminitis, means there's not enough BP going towards the lower limb and perfusing the other organs. So in this kind of situation, you look, if the upper limb BP high, lower limb BP is low, you need to assess the PDA patency. Okay, so if you see this, it's 100% oxygen, everyone is happy, everyone will leave the patient alone, and then just wait for IJN to take the patient. But this is not the case. So now you're actually dealing with a lot of blood flow going to the lung, and there's a lot of lung damage. So ideally, we want to look at this 90 to 95% over the right upper limb. Excellent. Okay, so 90 and 95. Okay, I'm finishing already. Okay, so the take-home message is sepsis is the most common cause of neonatal circulatory shock. Again, sepsis is the most common cause. Okay, so secure ABCDE first, intubate, breathing, circulation, give bolus, disability, check the sugar, environment, basically check, make sure the child is normothermium. Okay, LVOTO can occur at few levels, left ventricle, aortic valve, or aortic arch. And prostaglandin to release the LVOTO. So upper limb saturation target again, 90 to 95%. Don't want to look at 99 or 100% all the time. So 90 to 95% is enough. If it's too high, lower it. Lower limb BP target mean 40 to 45. Okay, thank you everyone for the attention. Okay, I will pass the time over to Shuko, who will come. See you on Joyce. Dr. Joyce, hand back to you first.
Yeah, thank you, Eugene, for the very informative case and also discussion. Yeah, I would like to actually open maybe for about just 5 minutes of question. But let's say if you have question that pop out of your mind later on, you can actually put it on the chat box. Yeah, wait for a couple of minutes for anyone.
So basically, yeah, thank you, Eugene, for really summarizing everything. The whole webinar is created to basically give some information to all the other peripheral hospitals outside because they are keeping our patients for us and needing to manage this group of patients is not easy, and they are going to be in your hospital for some time. So knowing how the physiology works and all that is quite important. For now, since diagnosis is not as complicated as previously, where you can easily ask for an echo, so diagnosis is usually doable in the peripheral hospital, even in fairly remote area. So once the diagnosis is made, you all usually do refer to us, and we try to get the patient over as soon as possible. But in the interim, it's still a long time. for y'all, is a few things that you all need to look out for. Number one is, of course, make sure the patient has good nutrition, get the patient fed. But while you all are doing that, you all also need to watch out for things like necrotizing enterocolitis, because the perfusion to the lower body might be compromised. So look out for all those things. And then while you feed, of course, you try to optimize as much as you can mother's breast milk. And then look out for heart failure features, because at the beginning, when the PVR is still high, maybe the patient may not be in such heart failure symptoms. But as the patient move along, you see the lung getting more and more congested. Really, the patient will start breathing heavier. And then as the patient starts breathing heavier, you might end up with more oxygen and put the patient on NIV. Also start some anti-failures if you think the patient is now starting to become more and more in heart failure state, breathing is starting to be heavy. And of course, like we said, after you have ensured that you have opened up the PDA, it's time to really look out for distal perfusion, things like your kidney. If you do not have enough perfusion to your kidney, you will start getting AKI. So look out for those things. And the gut perfusion, because you really can tell whether the patient is feeding well or not. Transaminitis. These things are really important for you to monitor your end organ. Because if they are not good, you may have to look out for repeat the echo again, see your PDA size. And of course, since the patient is sitting in the hospital, the chances of infection becomes really high. So you may need to screen the patient. You may need to look out for when the patient starts getting fever, febrile. Because another thing is you need lines. As you need lines, the patient will be on Prostin, and this will be extra line thrombosis, line infection. These things are going to increase your risk of infection. I
Alright.
hope you all have questions, because if you all
Yes.
have questions, then
Yes.
we can.
Yeah.
answer them.
Thank you, Sue, for the further explanation and sending the message across that, hey, look here, all this can be done, right? Yeah. So there's a question. I think this is a very good question. Thank you, Chan, for your question. Chan is asking whether is there any inotropic choice that you can use, especially in a co-op with poor cardiac contractility. So he's asking whether can you use dobutamine or dopamine. I think this is a very, very good question. Yeah.
Dr. Faizal wants to add on something?
Yeah.
Dr. Faizal muted.
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 Yes. Dr. Faizal, you have to
Okay.
unmute. Yes.
All right. So actually, thank you, Eugene, for the very detailed presentation. It's just that I would like to highlight those cases that you have a coarctation PDA close despite giving prostaglandin. I think this type of patient, I just want to highlight to everyone, if you have a condition where you have late presentation, patient presented very late and you are not able to open the PDA, and then LV function down and things like that. So this type of patient, you need to alert us early and we need to take as emergency lah. That's one. Secondly is that if you have, critical aortic stenosis lah, this is another emergency that, if the patient might not respond to even if you open up the PDA, because the coronary is going to be retrograde. So you need to actually, do urgent aortic valvuloplasty. So this also you need to need. The other thing is that if you have managed to open, because some of the peripheral hospital, what happened is that you managed to open the PDA, but because they're late presenter and because we are prenatally, we are not diagnosing them, right? So we usually, patient collapse, come into us. So by the time you open up the PDA, the end organ damage is already there. So I just want to highlight to everyone, because if, let's say, you need to do surgery, you need to make sure that there is organ recovery lah. Okay, even if you send to us with no urine, it's very difficult. So once the PDA is open, you need to treat the AKI. You need to do, even if you have to do dialysis, it's better at your center, and then get the creatinine at least less than 50, so that we can do the surgery. Because what happened during surgery is that we're going to be, I take cross clamp, that's going to further damage the kidney. So you need to make sure once PDA is open, you get some organ recovery before you send to us lah. So that's very important, because this is what usually, even if you send to us, we need to stabilize patient, we need to get the creatinine down, urine output good before we can send the patient for urgent surgery. So what was the question just now? About
Yeah, the question is inotrope. Yes, Dr. Faiza. What is the
Oh, yeah.
inotrope of choice for this left-sided disease with poor contractility? Can we use dobutamine or dopamine? I think this is a very good question.
Usually for left ventricular outflow tract obstruction, we cannot use inodilator, like, which is dobutamine, because that will further worsen the perfusion to the end organ. So we choose usually either you can use adrenaline or maybe dopamine. Dopamine we can sometimes prefer because the renal is going to encourage. Usually the patient will have some form of AKI, so we want some perfusion to the kidney, get the kidney better. So sometimes, dopamine can be considered lah, or adrenaline, depending on the condition of the patient. If the patient, so tachycardic also is going to be very difficult. Usually I find that the other thing I would like to highlight, because the organ that's going to be affected is the kidney. So sometimes you are running your tail, your positive balance, fluid overload, your patient going to be tachycardic, volume load. So you need to make sure there's some, urine output is there, and not too much positive fluid overload that can cause, tachycardia, low cardiac output, and it's like chasing your tail. So you need to be very vigilant about this. If you have problem with gaining negative balance, then maybe you need to consider early PD for, fluid extraction, things like that, rather than increasing inotropes. This is what I noticed also. If you have a lot of positive balance, then you are not able to control heart failure. So instead of increasing inotrope, you should try other things to, like fluid extraction, get the patient negative balance. So at least you can, the cardiac function can recover,
And Mirinon is also contraindicated.
Yeah,
right?
Mirinon is also
We also
contraindication.
don't use Mirinon for this left-sided obstruction. Yeah. I have I have a few more questions actually. One from the YouTube streaming. The question is, how much is distal perfusion that we need to target in the case to ensure adequate opening of PDA for lower limbs?
Yeah.
So you want to answer?
So usually what I would like to mention is that what you're looking out for is end organ perfusion. So if the patient has good urine output, he can tolerate feeding well, and you monitor your let's say if you take an RP and all that, they're still good, most likely you are still good. But the BP, if you are really to measure the BP, then it will be a minimum MAP for distal organ perfusion. Say the baby is a term baby, the MAP will be around 40, 45. So I would target something like this. In terms of saturation, it's often a bit difficult because if you have a contribution from the PDA, the saturation on the lower limb will be a bit lower. So if you, of course, the nurses, they cannot put the probe in the right hand all the time. So if you're going to put the probe in the lower limb, you need to understand that lower limb BP, lower limb saturation may be a little bit lower. So there's another mention here. I think the question says, how do you balance between maintaining a PDA and preventing a PDA steal? Just now, Eugene quite nicely mentioned that you see that the crossroad between getting blood in the lung or getting blood to the systemic circulation. So if you need the blood to get to the systemic circulation, you need to increase the PVR. He mentioned a few steps just now. He mentioned things like trying to drop the oxygen, allowing some degree of permissive hypercapnia, putting the patient on NIV, increasing the PEEP a little. Those things are all very helpful. And what is the dose range for prostin? So prostin for systemic circulation tends to be a bit lower, and we are usually quite okay when the prostin is around 5 to 10. That also most of the time the PDA will be open. But you need to make sure your line is good. Many a times when we receive calls to take the patient urgently, that is usually when the prostin line is bunk and people cannot pick it up. Then a few hours have passed before the patient doesn't have a prostin on. That can be tricky. So
So
yeah,
the other thing,
someone
so
to add something?
I would like to highlight to the, especially they are in neonatal period, kan? Sometimes what happen is that you will have a disaster if on top of the coarctation you have a PPHN on board lah. Because once you have that, then you have no choice but to bring down, you know, what Dr. Su said is for the normal patient with normal PVR, blah, blah. But you have PPHN on top of that, then in order to have circulation down, if you're severe coarctation, then you need to actually, you know, treat the PPHN so that you can get circulation down to the lower limbs lah. Because if you don't have blood going to the lungs, then how to get blood circulating down to the lower limb, right? So in these particular instances, then you need to actually balance it out lah. Yeah.
Okay. All right. Yeah.
Because the PBR, yes, you need to increase, but if you have on top of that, because sometimes very tricky, you have because you don't have circulation down to the lower limb and to the kidney and organ, so end up with PPHN. Usually the patient will be very difficult to make it lah. You know, very high mortality lah, unless you do the operation early when they are quite okay.
Okay. Yeah, thank you, Dr. Faiza. Yeah, one last question for this first case. Will CRRT be one of the consideration in AKI?
I think, like Dr. Faiza mentioned just now, PD is usually the best in neonates because many centers can actually insert PD. You have a surgeon on board, you can insert. Neonatologists also can insert. It is very low cost, easy to manage, and fairly gentle. CRRT, the problem with CRRT in the neonate is that the vessels are small, your vascat may be big, and not many centers actually have a vascat of a suitable size for neonate. On top of that, depends on the center whether they actually have a CRRT machine on. But of course, it's not a contraindication that you cannot use it.
But the thing so like I'm not sure because previously when we bought the Prisma flats, right? Because I actually asked Yap, apparently you know our Prisma flats, the FDA approved for 10 kilo and above only lah. For less than 10 kilo is like you know, it's on your own risk lah, at your own risk. But I think it's not unless you have a neonatal that's suitable lah. Maybe you can consider that lah. But I think since like you mentioned, PD is you know usually effective in our patient. So I think there's no reason to try CRT because CRT, you know, like you said, like the sheath, the machine, everything you need to have the equipment lah. And I don't know whether HTA now they're using what for neonatal. Do you have CRT? Anybody from HTA for neonatal? Anyone from HKL or nephro unit? Maybe can share. Huh?
Keep that lah.
I think tak ada lah kot. Maybe still PD lah, number one.
Yeah,
For
I think
neonatal.
still
Yeah.
peritoneal dialysis. Yeah. Okay, there's one question in the chat box. Why is Mirino not the inotrope of choice in the patient with this left heart disease?
Yeah. Like Dr. Faiza mentioned also, vasodilators are not good because if you have a fixed obstruction, when you vasodilate, you basically vasodilate the distal circulation. When that happens, what happens when you have a fixed obstruction? The gradient between the upper and lower becomes much bigger. That exacerbates the coarctation gradient and perfusion to the organ, because that area that has been coarcted, you cannot increase the size because it is a physical obstruction. So when you create vasodilatation, distally it becomes vasodilated, so the perfusion to the organ actually gets worse because you cannot increase the amount of blood flow you want to push across the fixed obstruction. If that answers the question. Anyway, I think we have to move on.
I will move on. Yeah. Thank you everyone for the question. We will move on to our second case discussion is the blue newborn cyanosis without distress. Yeah, I hand over to Dr. Shukur.
Okay, thank you so much. Sorry. Thank you so much. So we will do second case presentation for today. So this Dr. Eugene presented on systemic dependent sorry about the technical issue. Okay, so as Dr. Eugene has presented on drug-dependent systemic circulation, so I think it is not enough for that particular problem to be discussed without looking into the cyanosis one. So my topic for today will be the blue newborn, the cyanosis without distress. So this will be my learning objective for this particular discussion.
Syukur,
Yes.
your voice is like bergema lah.
Okay, hold on. How about now? Okay.
Can you speak again?
How about now?
Still. I'm not sure the others.
Clearly, yeah.
Can not really clear lah.
Oh.
Are we clear now?
Still dah, tapi tak apalah, proceed je lah.
Can you hear clearly now?
Yeah.
The mic just bring closer to you. Then we use the computers. It's a okay.
Okay, can everyone hear me? Can everyone hear me clearly?
Yes.
Okay, all right. So I'll be presenting the second topic for our inaugural PCRC webinar. So as it is a case discussion or grand round concept, so my presentation will be based on one case, two cases, but the first case will be long as we go along, so that we learn how to get more information and also to manage the patient. So this will be the learning objectives for my presentation. So the first one is actually, of course, to distinguish the types of cyanosis. And of course, in the case of emergency, we have to recognize the red flags that we have to deal with. And of course, we need to build differential diagnosis in order for us to manage our patient correctly, and also outline the initial stabilization in cyanotic infant, and also interpret diagnostic tools. All right, so let us kickstart the presentation with the case description. So this is a term baby with weight of 3.9 kg who was delivered elective caesar for 2 previous car. So this particular, this boy cried immediately after birth. However, his whole body appeared blue that did not improve with suctioning and stimulation. And these are the initial vital signs. The heart rate was 110 beats per minute with SpO2 was only 40% under room air. Of course, everyone is familiar with neonatal resuscitation program. As with NRP, we have 3 screening questions. So as for, I'm sorry, before that, this is the background history for the patient. So the maternal history is basically unremarkable. So this patient, the mother went in for elective caesar, did not require any antibiotic treatment because it is an elective cesarean section, and there is no risk of sepsis. So as I mentioned before, according to NRP, we do have 3 screening questions. So same goes to approach to cyanotic infant. We do have some questions and also initial information that we have to elicit. So maybe you can give a shout on the chat box. What are the information that you want to know and also why? So it is a bit difficult to have a two-way communication on our webinar, but I think this might help to jog our mind so that we can have some discussion later on. So these are the 3 important informations that we have to know whenever we attend to a cyanotic infant. So first, of course, we want to know what is the breathing effort, the description of the breathing effort, the pre and also post-ductal oxygen saturations, and if is there any improvement of cyanosis with oxygen supplementation. So I will go through one by one for these points. So in terms of description on breathing effort, so the rationale for information for this particular question is the presence of respiratory distress, namely grunting, nasoflaring, or retractions are abnormal, and these physical signs are attributable to lung disease, upper airway obstruction, metabolic acidosis, or other stresses on the ventilatory system, which we will go through later. If there is no respiratory distress in a cyanotic patient, or patient is tachypneic in the absence of distress, cyanosis may be likely due to some forms of cardiac disease. So as we go to this particular case, the infant was tachypneic with mild retractions and nasal flaring, and this patient did not improve with the use of NIV. So for second part of the question, so is there any improvement of cyanosis with oxygen? So we want to know the improvement of cyanosis with oxygen because cyanosis that improves with oxygen indicates that sufficient blood flow enters the lungs and that oxygenated blood reaches the systemic circulations without mixing with the oxygenated blood. And if the cyanosis persists despite oxygen supplementation, we know that there is an inadequate pulmonary blood flow, or there is an intracardiac mixing of oxygenated and deoxygenated blood, or there is an oxygenated blood that does not reach systemic circulation. So going back to our case just now, so for this particular patient, after initiation of CPAP with 100% of oxygen, SpO2 indicated an increase in SpO2 with a peak of only 72%, which is, of course, inadequate. And of course, you want to know about the pre- and post-ductal oxygen saturations, as it will help in narrowing down the differential diagnosis in cyanotic infant. So this is one important diagram that we have to understand, especially when we deal with neonates, infants on day-to-day basis. So the first is actually about the shunting through the patent ductus arteriosus. So pre and post ductal saturations in normal and abnormal cardiac anatomy and also physiology. If we go to the first box, which is box A, so this is a normal cardiac anatomy and physiology whereby the blood is shunted through PDA from aorta to pulmonary artery, or what we call as left to right shunt through PDA. So this is in particular will not cause any cyanosis. So as we go into box B, the pulmonary artery to aorta. So as we can see from the arrow here, the blood is shunted from the pulmonary circulation into aortic or systemic circulation. So that this might be because of normal cardiac anatomy, and at the same time, the patient has persistent pulmonary hypertension of the newborn, whereby the pulmonary pressure is higher than the systemic circulation, causing right to left shunt, and there is a differential cyanosis for this patient. Then you move on to box C, pulmonary artery to aorta. The direction of the shunt is from the pulmonary to aorta or systemic circulation. So if let's say this thing happened, one of the differential diagnoses is whether the patient has cyanotic infarct, namely TGA anatomy with pulmonary hypertension. And for box D, specifically when there is aorta, left to right shunt from aorta to the pulmonary circulation. So this particular patient might be having TGA anatomy without pulmonary hypertension. So for our patient, the pre and post-ductal SpO2 were 72% at pre-ductal level and also 74% at the post-ductal level. So going back to our patient, so the vital signs for the patient is afebrile, heart rate is borderline tachycardic at 160 beats per minute, respiratory rate of 54 breaths per minute, slightly tachypneic with normal blood pressure. SpO2, as mentioned before, is at least 72% pre-ductal and 74% post-ductal. Infant remains cyanotic, with most prominent at the upper body with no apparent dysmorphic features. Systemic examinations, namely lungs, were clear to auscultation, but the infant was mildly tachypneic with mild subclassial recession. So the precordial impulse, however, was of normal intensity, palpated in the left chest, and also peripheral pulses were strong in all extremities. Of course, at this point of time, maybe the audience or those attending these particular patients will have differential diagnosis in their minds. So how are we going to go through the patient? So putting the case thus far, the key features for the case are immediate and profound hypoxemia after birth and mild respiratory distress with minimal improvement with oxygen therapy. So the key point for this particular patient is immediate and profound hypoxemia. So another important point when we attend to a patient who is cyanosed, so we have to differentiate between the terms cyanosis, hypoxemia, and also hypoxia. Whether the patient is only cyanosed, which is blue appearance of the skin, or the patient is cyanosed and also hypoxemia, which is a low oxygen tension in the bloodstream, or the patient is hypoxic as well, whereby it is defined as the low oxygen tension in the tissues. So this is important because the differential diagnosis of cyanotic patient will have some of these particular elements, whether it's cyanosis, hypoxemia, or hypoxia, or a combination of 2 or 3 elements as well. So, of course, some of us will have a framework of approach to differential diagnosis of cyanosis. For me, personally, I like to go to the differential diagnosis based on the physiology. Okay, so for example, for other systems like in neuro, you have approach to weakness. So you have the different stages like neuromuscular junction, muscles, brain, and all. So same goes to approach to differential diagnosis for cyanotic infant. In order for a patient, regardless whether it is infants or adult patient, to have a normal oxygen level, or in other words, they are not cyanosed, they have to fulfill all these particular physiological series. So the first, inspired oxygen reaches the alveolar capillary units through adequate ventilation. So the ventilation has to be normal. And at the same time, deoxygenated blood flows through the pulmonary arteries to alveolar capillary units. So the blood, deoxygenated blood is pumped from the blood to the lungs. So this has to occur without any difficulty and without any defect. And in the alveolus, oxygen diffuses from the airspace into the capillary blood. So the oxygen needs to diffuse from the alveolar into the capillary blood. So there shouldn't be any obstruction. And oxygen binds the hemoglobin flowing through pulmonary arteries. And the last is actually oxygenated blood from all regions of the lungs mixes together as it returns to the left side of the heart and is pumped to the systemic circulation. All right. So get familiar with this physiology, or what I call as physiology of oxygenation. In order for us to have a normal oxygen, all these particular elements in the physiology of oxygenation has to be normal. If let's say there is any defect, then that will produce a patient with cyanosis. So let's go through one by one. So for the first part, inspired oxygen reaches the alveolar capillary units through adequate ventilation. So what can go wrong in this particular element? So inspired oxygen cannot reach alveolar capillary units can be due to inadequate ventilation due to neurologic dysfunction. For example, those patients, specifically in neonates, those patients who suffer from hypoxic ischemic encephalopathy, or the patient can have an exposure to sedation during delivery that can cause the patient to have respiratory depression, which will produce cyanosis. And or the patient will have mechanical obstruction to ventilation. For example, they will have macronetia or cranial atresia. So this will cause the patient to have cyanosis as well. So for the second part, which is deoxygenated blood flows through the pulmonary arteries to alveolar capillary units, what can go wrong in this particular aspect is that if, let's say, there is an inadequate pulmonary blood flow with right to left shunt due to elevated pulmonary pressures, which is hyper-PPHN, who is not afraid of PPHN. I think you cannot sleep at night if you are on call in an ICU if your patient is PPHN. And of course, if you can have inadequate pulmonary blood flow with right to left shunt, of course, certain congenital heart disease, for example, pathology of Fellow or Epstein anomaly, and certain congenital heart disease with normal or increased pulmonary blood flow, but has intracardiac mixing, for example, truncus arteriosus or hypoplastic left heart syndrome, which is not that common to have hypoplastic left heart syndrome in our society. So then as we go along, the oxygen needs to be able to diffuse from airspace into capillary blood. So if, let's say, the patient has any alveolar or interstitial lung disease, for example, the most common or things that we deal in neonatal setting is meconium aspiration syndrome or pneumonia. But for our patient just now, the patient does not have any risk factors for infection. And also at the same time, the patient is not post-date that might predispose the patient to be having MAS. So at the same time, there will be, if there is any extrinsic and compression of lungs leading to inadequate ventilation of some alveolar capillary units. So for example, conditions like pleural effusion or pneumothorax. So move on to the oxygen that binds to hemoglobin flowing through pulmonary capillaries. So only one particular condition like methemoglobinemia, which inhibits the oxygen to bind normally to hemoglobin. And the last part or the last element for us to have a good oxygenation is that oxygenated blood from all regions of the lungs mixes together as it returns to the left side of the heart and is pumped to the systemic circulation. So, for example, in TGA, whereby oxygenated blood cannot reach the systemic circulation because of parallel circulation, as we can see in the diagram. So, what further tests that we want to do? Okay, going back to our patients, we know that the patient is severely cyanosed, which does not improve with any oxygen supplementation. And at the same time, the patient has mild respiratory distress as well. Of course, you can throw a lot of other investigations at the same time to help us with any differential diagnosis. But for me personally, these are the main investigations that will help us in determining whether the patient, in helping us making a differential diagnosis. Of course, an arterial blood gas is very important because we want to assess the degree of metabolic and also respiratory acidosis. And of course, we want to gauge what is the hypoxemia, whether the patient has any hypoxemia or not, in the sense that normal PaO2 for the patient. And secondly, a glucose level. Hypoglycemia can cause cyanosis via neurologic dysfunction, apnea or inadequate activation of the muscles, and ventilation. And of course, some of the centers, we don't do glucose level below 4 hours of life. And subsequently, we want to do full blood count. Of course, we want to see whether there is any likelihood of infection. Chest radiograph, of course, one of the most important things that we want to rule out if there is any congenital pneumonia. And also, ultimately, echocardiogram to evaluate any presence of congenital heart disease that can cause cyanosis. So these are the investigations result for our patient. So remember our patient just now. As we can see, the blood gases, it is respiratory acidosis, or what we call as type 2 respiratory failure. The PaCO2 is elevated with acidosis. And at the same time, there is a hypoxemia as well with PaO2 of only 25.9. The ones I found otherwise is unremarkable with normal differentials. But if let's say you guys can give a shout, how can you describe the chest X-ray for this particular patient? And of course, you can see that there is a bit. It is not truly oligemic. There is still haziness bilateral lung fields, but there is a presence of a bit of cardiomegaly, or what we call as ache on string. All right, so this is a clue for our diagnosis for our patient. So glucose otherwise normal. So let's refine our differential diagnosis. So the patient is likely to have a bit of normal chest X-ray, less likely to have respiratory in origin. Congenital heart disease, for example, Epstein anomaly, is very much less likely due to normal size heart, and also the severity and the time of onset of hypoxemia. So congenital heart disease with intracardiac mixing normally will cause only mild hypoxemia with SpO2 of at least 80%. So namely like trancus arteriosus, those patients with hypoplastic left heart syndrome, they will have hypoxis, they will have cyanosis, but it will not be that severe as our patient. So congenital heart disease with obstruction to pulmonary blood flow, normally they will have mild hypoxemia as well at birth, but at the same time, it does not progress to severe hypoxemia until a few days of life because of the presence of the patent ductus arteriosus. So this particular patient, as I mentioned, the pre-ductal SpO2 was 72% and post-ductal SpO2 was 74%, and it is less likely to be PPHN. And the patient has cyanosis, but with no hypoxia, it is unlikely that the patient has methemoglobinemia. Normally, for the patient with meth, so they will have cyanosis, but the PO2 will be normal. So this is the things that we can strike off. Of course, we cannot say that this patient, the first part is abnormal because so far it is bit inadequate information to rule out the first part of the defect in the oxygenation physiology. However, it is a bit unlikely because the birth history is a bit unremarkable. There is no risk factors to have, for this particular patient, to have hypoxemic injury as well. So the last, everything that we have struck off, and then the thing that we cannot rule out at the moment is actually oxygenated blood that cannot reach the systemic circulation, or in other words, that the patient has parallel circulation, namely in TGA condition. So going back to our patient, due to ongoing hypoxemia and respiratory distress, infant was intubated. There's nothing wrong with that. And the repeated atrial blood gas showed normalizing PaCO2, however, still with profound hypoxemia. pH is 7.34, PaCO2 is 44. We managed to normalize the PaCO2, and also the PO2, however, remains low. So respiratory compliance was normal based on our ventilator setting and also the feedback from the ventilator. Excuse me. However, our patient remained hypoxemic. So given the severity and persistent hypoxemia, what would you do? Of course, I think majority of us will have this experience of dealing with hypoxic patient. So what you think you will do at this particular of time, given all the information that you have available at the moment? Okay. This is an old test, but I think it is still applicable. But I know majority of NICU does not practice hypoxia test anymore. I think you will have better echo machines than the one that we have in IJN. So hypoxia test, the initial method to distinguish between congenital cardiac heart disease from pulmonary disease. The test actually consists of measuring an arterial blood gas. So the keyword is arterial blood gas at room air, and at the same time, 100% inspired oxygen after 10 minutes. Okay, so the test duration is only 10 minutes. It is not 30 minutes. It is not 1 hour. And units with congenital heart disease are usually not able to increase PO2 above 100 millimeter mercury during 100% oxygen administration. So this is the basis of the test, and also in patients with pulmonary disease, PO2 generally increase greater than or equal than 100 millimeter mercury with presence of 100% oxygen. So the positive results might indicate the cardiac origin of cyanosis, and further cardiac workup is indicated to rule out congenital cardiac heart disease. Okay, so of course you all suspect that this patient has cyanotic congenital heart disease. So of course, some knee-jerk reflex, we start the patient on IV prostaglandin. But it is not a knee-jerk reflex. It is actually based on a guideline. So this particular guideline mentioned that immediate priority after birth and throughout first few hours of life for patients with suspected cyanotic heart disease before we determine whether the mixing between systemic and peripheral circulation is adequate or not. So the initiation of prostaglandin is very much recommended to maintain ductal patency until comprehensive series of postnatal echocardiograms is complete. So this particular recommendation is not just based on the patients who is not diagnosed with congenital heart disease, but for those patients who are already diagnosed prenatally with a good fetal echo, for example, prenatally diagnosed with TGA, if, say, for example, the patient has cyanosis, it is actually recommended to start prostaglandin as well based on this particular guideline. Nevertheless, the use of prostaglandin may not suffice. So because the ductal shunting is often inadequate, which I will show in a while, and there are no absolute contraindication to starting prostaglandin, although it may worsen pulmonary edema associated with obstructed TAPVD. So bearing in mind that prostaglandin is important to start early, but at the same time, we have to make an effort to diagnose the actual congenital heart disease using an echo or a trunk referral to a cardiac center. So going back to our patient, the echo confirmed the diagnosis of TGA with intact and small restrictive atrial communication, and the infant received treatment with sedation and neuromuscular blockade, and guided volume resuscitation and dopamine were initiated to treat hypotension, and prostaglandin was continued to maintain ductal dependency. And despite this intervention, the hypoxemia persists to worsen with prenatal SpO2 below 60%. Maybe some of you might ask why this particular management is in place, which I will elaborate a bit later. And also, infant was then transferred to tertiary cardiac center to undergo balloon atrial septostomy. Okay, a bit on TGA. TGA is a leading cause of cyanotic heart disease in neonates, and the main symptom is cyanosis. But they sometimes don't present with cyanosis alone. So in infants with TGA and intact interventricular septum, that means with no VSD, and a restrictive PFO and ASD, severe cyanosis and metabolic acidosis develop rapidly. So this is the case for our patient. Often we need within the first hours of life. So they have a very restrictive PFO, there is no interventricular communication, and they develop subsequently severe cyanosis and metabolic acidosis. But when there is a large ASD or PFO allowing adequate atrial mixing, cyanosis can be mild, and we can miss this group of patients, and the infant may show minimal signs of heart disease initially. And physical examinations can be unremarkable as well. So in patients with TGA and VSD, clinical presentation varies based on the VSD size and associated lesions as well. So a large VSD may allow significant mixing, but can lead to increased blood flow. Hence, the patient can have signs of heart failure later. Okay, so this is quite, a lot of centers ask what is the optimal level of SpO2 for the patient. So SpO2 should be targeted at 75 to 85%. And sometimes in preterm newborns, we can accept the SpO2 range as low as 70%. However, knowing SpO2 monitoring, especially in neonates, especially when the level is below 80%, is very limited. We have, or is a bit imperative to monitor arterial blood gas as well. So the target PaO2 for arterial blood gas in cyanotic heart disease, namely in TGA as well, is between 35 to 45 millimeter mercury. So for neonates with profound hypoxemia, which is defined as PaO2 of less than 25 millimeter mercury, or severely cyanosed with SpO2 of less than 60%. So this particular patient requires urgent attention, though they might fall in the first group of patients with TGA, which is inadequate mixing, restrictive interarterial communication, intact interventricular septum, or closing PDA. Oxygen should be provided. However, there are concerns about the potential risks associated with therapy. So we have to know extreme hypoxia will cause oxidative stress and potentially damage the lung parenchyma as vascular function. and the usage of 100% oxygen will cause nitrogen washout from your alveoli or small airway, which will predispose the alveoli to have atelectasis. So the use of 100% oxygen should be avoided at the outset when, of course, we have a high degree of suspicion that this patient might be having cyanotic heart disease. So don't target SpO2 beyond 85%. Keep it between 75 to 85%, and please don't use SpO2 of 100%. So let's talk about a bit on the mixing of parallel circuit. Of course, in terms of mixing, there are a few sites of mixing, namely inter-arterial communication, namely ASD and PFO, PDA, and also VSD. So the best is actually at the ASD PFO, which has the advantage of early low pressure mixing before the ventricular contraction, and the restriction can cause some severe cyanosis. PDA can be acceptable, but it is not as best as ASD because, of course, it will maintain temporary survival before the patient can go on for a definite surgical intervention, or if, let's say, the patient go into severe cyanosis hypoxemia, you can go into BUS. VSD is variable, but of course, it can cause a large volume mixing, and sometimes it can go into congestive heart failure and pulmonary overcirculation. So when people ask you why is arterial level mixing is the best in TGA, because mixing occurs proximally in low pressure compliant chambers before ventricular ejection, and it allows more effective distribution of oxygenated blood to the systemic circulation. So these are the strategies to improve tissue oxygen delivery. So we know the patient is cyanosed, we know that the patient is hypoxemia. So these are the strategies that we can do, okay, to improve the oxygenation. So of course, prostate, as I mentioned, BUS, and mild hyperventilation and increase FiO2 to lower pulmonary vascular resistance and increase pulmonary blood flow at the same time. Transfusion to treat relative anemia and increase oxygen carrying capacity in order for us to deliver tissue to oxygen to the tissue. So we have to make sure that the patient, sometimes target hemoglobin level of between 13 to 15 is adequate for the patient. And of course, sedation and paralysis to decrease oxygen consumption. I know that for our NICU, so normally in our local setting, we rarely use any neuromuscular blockade, but certain guidelines do suggest the use of neuromuscular blockade so that they can reduce the oxygen consumption. And inotropic support to increase cardiac output and also oxygen delivery. Sometimes you can use dopamine as well. So, of course, the patient required BUS, oxygen saturation improved to 75%. And day 8 of life, which is an ideal situation, the patient went for surgical intervention, namely arterial switch operation. Okay, so those are the approach to a cyanotic infant. So let us try to apply what we learned so far. In our case, it will be a very short case. So it's a day 2, 2-day-old term boy. It's referred from district hospital for progressive cyanosis. So unremarkable birth history, well at birth. However, at 12 hours of life, started to give problem, increasing central cyanosis with oxygen saturation of 70-78%. Minimal respiratory distress, good breathing effort. However, has poor response to oxygen therapy. So a bit different from the first case that we have, namely patient well at birth. However, at 12 hours of life, started to become cyanosed. So 3 screening questions that we have to ask: description on breathing effort, pre and post-datal oxygen saturation, and also improvement of cyanosis with oxygen. So I've mentioned that this particular patient, saturation remained low after oxygen supplementation being given. So framework approach, of course, we want to know whether the patient has any defect at any point of physiological changes in oxygenation. So the patient has central cyanosis with minimal tachypnea. Vital signs are fairly unremarkable except for the SpO2. Respiratory is a bit tachypnic. Single S2 on cardiovascular examination. So for those of you who are well familiar with the congenital heart disease, maybe you have your differential diagnosis as well back to your mind by now. There's a soft systolic murmur, mild precordial activity with no significant hepatomegaly. So respiratory examinations, fairly unremarkable. So the clinical clue for this patient is severe cyanosis with relatively comfortable breathing, suggests cyanotic congenital heart disease. So this is the chest X-ray for the patient. Very much cardiomegaly with fairly oligemic bilateral lung fills. Summation hepatocytes was done, minimal improvement in PaO2, and also there is a right atrial enlargement, left ventricle dominance, and also small RV forces based on the ECG. So, congratulations for those who answered it correctly. So this patient has PAIVS. So classical neonatal clues for PAIVS, normally they will come with severe cyanosis, but they will be dependent on the PDA. Well, very minimal pediatric respiratory distress, poor response to oxygen supplementation. Main thing to highlight is actually single S2. So basically, they will have pneumonia atresia. So the P2 component will be silent. And also, this is adult-dependent pulmonary circulation. So, going to the last slide, the take-home points for this particular discussion is that congenital heart disease should be suspected in newborns with hypoxemia refractory to oxygen therapy. So, it is not wrong to give oxygen, but it is wrong to leave the patient to be in hypoxic test. So, main take-point message is that prostatin should be initiated early once there is suspicion of ductal-dependent pulmonary circulation, and target SpO2 for congenital heart disease should be identified. Cautious titration of FiO2 should be done, and attempts should be made to avoid usage of high FiO2. Thank you. So I'll hand back to Dr. Joyce to moderate the Q&A session.
Thank you, Shukor, for the very useful, informative presentation. Is there any question from the floor?
Yeah. Thank you, Shukor.
Yeah.
Very nice that you've gone through the approach on cyanosis. That shows that we have not forgotten all our general neonatal work as well. Going through all the steps is what we usually would like everybody to do to come to a point of diagnosis. I think in terms of making a diagnosis, the thing that often tricky is that what if the patient has PPHN? That would be the thing that you all tend to think about first before you all think about cardiac diagnosis. And in PPHN, sometimes even when you screen the time, you see, a very large right-sided heart, a lot of frank right to left shunt at the PFO. You think the patient may have PPHN. So there's still one diagnosis that it's a bit more difficult to pick up, even though you have done an echo. That will be TAPVD. Because TAPVD will also have right-sided heart dominance, and then a very big right to left shunt at the PFO level. If you do not screen the pulmonary veins properly, then it might be difficult to see. Even when you do an X-ray, you see ground glass, very white things that gives you a suspect of MAS with PPHN. That is also something that is common. So it may be difficult to rule them out. But if you have done a good echo, that would be good. And in terms of the subsequent management, once you have made the diagnosis, you have started the prostatin, the patient is stable and well. Nutrition and all that, again, need to emphasize nutrition, get them good sized, and then get them ensure that they don't get infection. That those things are important. And in terms of the prostatin level for cyanotic heart disease versus the systemic circulation duct dependence, the amount of prostatin, the dose of prostatin that you tend to use for cyanotic heart may be higher than those that are in the systemic circulation duct dependence, such as in the like just now I mentioned the lower dose of maybe 5 to 10 in the systemic circulation. you may use maybe 10 to 20 for your pulmonary circulation. And if you need to open up the duct, sometimes you might need a very high dose that even goes to 100 mics. But that usually we wouldn't recommend putting it on for long. Maybe only to test it out for 1 or 2 hours, then you have to bring it down. If it doesn't work, maybe you got the wrong diagnosis or the delivery of a prostate is not good enough. Yeah.
Thank you. Yeah, there's one question in the chat box. How about the risk of ductus arteriosus closure during the high FiO2 100% test? Should we start the test after we initiate the prostate? That 10 minutes hyperoxia test. Yeah.
The typical hyperoxia test is done before you start the prostate.
Yeah,
Yeah.
I think 10 minutes I think is okay because we usually do hyperoxic test at very early in the newborn. Yeah, within that few hours where you are not sure of the diagnosis. Yeah, so the hyperoxic test actually comes in very early in the neonatal life. Yeah. Any other question from the floor? No. All right. Should we conclude this webinar?
Well, this thing, the whole webinar was Dr. Joyce's idea. So she thinks that this is a really good information that we need to give to everybody, because a lot of times these patients sit in your hospital for a longer period of time before they come over to our hospital. So knowing a little on how to manage them, I think is important. Helps you and helps us as well. Bringing the patient in a very stable condition, that is also a very good thing for you and us. So this is only a starter. There will be other of such series along the way. So it will be good for you all to give us feedback as to whether this format is best for information dissemination or not. And then whether we actually gave you all enough information. What kind of topics do you all want? Do you all want to hear different topics? We have outlined some topics that we want to tell you all, because these are important topics. So we have them in, maybe we will do it once in 2 months or 3 months or so. If there are topics that you specifically want earlier, maybe we will bring it up earlier. But we want to know your feedback so that we can plan this to be able to disseminate as much information as we can within this short time.
Okay, I think there's a comment in the chat box that says PPHN and cyanotic heart disease is very hard, especially in district hospital without neonatologists. Any clue to help
Registration link feedback some.
And echo is very helpful, but usually it's not clear cut and tough to decide. Yeah, we have been there as well.
Yeah, I mean, it is a difficult thing to do, but like we said, things like X-ray, the one that is most difficult in terms of cyanotic heart disease is probably TAPVD. But there are a few TAPVDs. Your supracardiac TAPVD is the one that typically gives you the snowman in snowstorm appearance. So, and those patients with congenital heart disease, yeah, if you have cardiomegaly, maybe that's another point to note. If you see any parts of the heart that you're not comfortable with, then call somebody, and then pick it out.
Yeah, I think we also recognize that PPHN with TGA is really a disaster. Yeah, moving the patient from a primary hospital to the heart center is not going to be easy. It will be a high risk transfer because the patient is very blue, may not make it to a heart center as well. And despite us starting on INO, bars and all, is not so easy to stabilize. We have bad ones coming to us as well. Yeah. Thank you so much for everyone today for attending this webinar. I would like to also suggest, if you have any interesting cases at your center and you want to put it up for discussion with us, you can always email us and let us know. Then we can actually have this webinar as part of our case discussion as well. Yeah, we will give time to slot in your cases for discussion. Yeah,
Maybe that is a good suggestion also, no? If you all
Yeah.
have cases, you all really want to know how to manage, maybe it was a bit tricky on your side, you can bring it up and we can discuss it live also.
Yeah. This
Alright.
is meant for everyone to learn together. We are all learning together, right? Yeah. So I think I will conclude this webinar. Thank you everyone for spending your time with us today. Yeah. Look out for the next coming up webinar in a couple of months. Yeah. All right. Thank you so much. There's some more chance that maybe we can talk more on TAPVD soon. Okay, we will keep it in mind. Yeah. All right. Thank you. Thank you, everyone. Okay. Bye-bye. Yeah.
Thanks, Shuko. Thanks, Eugene.
Thank you.
Good
Thank you,
job.
Eugene. Yep. Thank you.
Good job. Go down. Another one to go.
The best people to start.
Masih tak you.